Hello, in this section I will talk about smoking and its implication on anesthesia. Now, smoking is one of the leading cause of preventable morbidity and premature death in an individual. Most of the smokers, they quit smoking, but because of the addictive nature of the smoking, because of the presence of nicotine in it, they are unable to do without any external assistance only in 2 to 4%. Now, perioperative time period gives anesthesiologist a golden opportunity to make them aware of the ill effects of smoking and help in smoking cessation. In this section, I will talk about those ill effects of smoking, and as an anesthesiologist, what special precautions that we need to take when we take a smoker for anesthesia, or especially for general anesthesia. As an anesthesiologist, we should be aware the smoking has its ill effect on cardiovascular system. So, smoking has ill effect on many systems, ill effects on multiple systems. So, grossly, what are the systems which are affected by smoking? Most important system which is primarily affected by the direct effect of smoking and by indirect effect due to presence of different substance in the cigarette is your respiratory system. So, the respiratory system or the pulmonary system is the most affected system. After respiratory system, the second system which is most affected is cardiovascular system. Cardiovascular system. So, lot of in smokers, lot of cardiac comorbidity has been seen to be associated due to presence of nicotine in the tobacco. Then, apart from this, neurological system is also affected to some extent, which we will discuss. The risk of infection is higher in the smoker. So, risk of infection is higher in the smoker, the risk of wound infection, then wound infection as well as general infection. Now, post-op pain, because of effect on central nervous system, they have increased sensitivity for the pain. So, post-op pain management is a bit difficult in these patients. So, difficult post-op pain management, difficult post-operative pain management. And lot of these patients, they may require ICU admission because of the ill effects happening on the respiratory or cardiovascular system if we are not aware and not taking proper precaution. So, in smokers compared to the general population, the incidence of ICU admission after anesthesia and incidence of prolonged hospital stay has also been seen to be more. So, increased incidence of ICU admission and increased incidence of prolonged hospital stay. So, we should make the patient aware of all these ill effects of smoking during perioperative period, and different societies like your ASA, the professional societies like ASA, the European Society of Anesthesiologists, recommends the anesthesiologist to make the individual aware of the ill effect of smoking, aware of all these ill effects, and contribute in cessation of smoking. So, ASA or ESA, what they say? They say to use the perioperative period, they recommend to use the perioperative period as a teachable moment to promote smoking cessation. So, if as an anesthesiologist we get a smoker and we are teaching them and telling them about the ill effects of smoking and helping them in smoking cessation, it is something what we are doing is right. We have been given this responsibility to use this opportunity as a teachable moment to help them in smoking cessation. So, what is the problem with smoking? We also need to be aware what is present in a cigarette smoke which make it so bad, which make it having so many ill effects on different system. So, the particulate matter is present in the cigarette smoke, and the gaseous state of the cigarette smoke. It's a smoke. Both have their own implications. So what is a cigarette smoke? If I simply ask you, you would answer me, it's a particulate matter suspended in the gaseous state. So we need to be aware of that particulate content of that particulate matter also, and we need to be aware of the gases which are present in the gaseous state. So cigarette smoke is particulate matter suspended in gaseous phase. And what are the gases present? Your nitrogen, oxygen, carbon dioxide and carbon monoxide. And the particulate matter which is suspended, they have at 7,000 chemicals, at least 7,000 chemicals present in them, and out of those 7,000 chemicals, 70 chemicals are carcinogens. 70 chemicals roundabout are carcinogen. Now in smoke, cigarette smoke, we have nicotine, and this nicotine is responsible for the addiction. It is responsible for addiction. Now nicotine acts, it's an agonist on nicotinic cholinergic receptor. So nicotine is basically, this is agonist of nicotine cholinergic receptor, nicotine acetyl cholinergic receptor, right? So its implication is because of its agonist effect on nicotine acetyl cholinergic receptor. And apart from that, in the smoke we have carbon monoxide. Carbon monoxide itself produces a lot of ill effect in the body. Carbon monoxide absorption, I mean, it's carbon monoxide can combine with hemoglobin in having a higher affinity. It has a higher affinity to combine with hemoglobin to form the carboxyhemoglobin. So in the blood of the smokers, normally, routinely, 15% carboxyhemoglobin is present. And carboxyhemoglobin, because of its increased affinity for the oxygen, they do not let the unloading of oxygen to happen. So risk of hypoxia in the patient increases. So carbon monoxide, which is present in the smoke, binds with hemoglobin. It has 250-fold more affinity than any other gas to combine with hemoglobin, right? And half-life of your carboxyhemoglobin is also very high. Half-life is minimum 4 hours, and this causes the leftward shift of the oxyhemoglobin curve. Leftward shift. So leftward shift, what will happen? If it's a leftward shift, the unloading of the oxygen will be decreased. So we all know on leftward shift, oxygen affinity is more, so unloading does not happen. Rightward shift causes the unloading of oxygen. And in smokers, 15% of the hemoglobin is your carboxyhemoglobin. So it will bear the ill effect on let's say oxygen delivery as well, and would contribute in hypoxia. So let us see that what is the physiological effect of smoking on different system. So I would discuss here the different system, the physiological effect on different system. I would start with cardiovascular system. I would discuss respiratory system. I would discuss the neurological system. What is the effect on your central nervous system, and I would also discuss what is the effect of smoking on metabolism, right? The smoking can induce the enzymatic metabolism. So metabolism of some of the drugs is accelerated. So we have to plan our dosing of the drug keeping this in mind. So everything I will discuss. So let us start our discussion with cardiovascular system. And major effect of smoking on cardiovascular system is because of the nicotine present in it. What does the nicotine do? Now, what nicotine does, it resets the carotid and aortic baroreceptors and leads to your increase in blood pressure and increase in heart rate in patient. Apart from that, it causes constriction, vasoconstriction of the coronary arteries. So let's say at one hand it increases blood pressure and heart rate, on other hand it causes vasoconstriction of the coronary vessel. So from this side the supply is less, and from this side it increases the demand. So this oxygen mismatch, oxygen requirement and delivery mismatch happens, and this can lead to myocardial ischemia, and this can lead to innumerable problems in the patient, right? So one thing before I start with the cardiovascular system, I would say that smoking has been said to be the major modifiable risk factor which increases 3 times the cardiovascular risk than general population. So this is on cardiovascular system, smoking is major modifiable risk factor, right? Major modifiable risk factor which increases threefold incidence of cardiovascular death, right? So it's a major modifiable risk factors. In smokers compared to general population, the risk of cardiovascular death is threefold more. Okay, so let's talk about the effect of smoking on cardiovascular system. As I said, the effect is because of the nicotine. So nicotine, what does it do? Nicotine promotes the carotid and the aortic baroreceptors resetting. It promotes carotid and aortic baroreceptor resetting, right? So it promotes the resetting, and this resetting causes increase in sympathetic tone, and this leads to increase in blood pressure, increase in heart rate, and also increase in heart contractility. So overall it increases the oxygen demand of the heart. So all this feature would cause increased oxygen demand, and because of coronary vasoconstriction, as I told you, there is a decreased oxygen supply, and this leads to mismatch, and this can precipitate myocardial ischemia, myocardial infarction in patients, right? Now apart from that, smoking is related to polycythemia, which would again affect the oxygen delivery, right? So it is related in smokers. There's a risk of association of polycythemia, right? Then thrombocytosis, right? Then it causes the acceleration of atherosclerosis. So association of atherosclerosis in long-standing smokers. So all these features, and especially what it creates, the mismatch of oxygen supply and demand, increases the cardiovascular risk in smokers. So this is the effect on cardiovascular system. But the major effect is on respiratory system, direct effect of the smoke and indirect effect because of the content of the smoke. So respiratory system exposed to the greatest concentration of the toxic substance, right? This is respiratory system is exposed to greatest concentration of toxic substance from the cigarette smoke, right? The local effect of the smoke in smoker is on the respiratory tract, the mucociliary lining of the respiratory tract. So what does it do? It impairs the mucociliary clearance and causes the mucus to stick in the respiratory mucosa, and all this increases the respiratory risk in the patient. So this impairs. The direct effect is impairment of mucociliary clearance by damaging the cilia which is lining the respiratory tract. Mucociliary clearance by damaging, the smoke damages the cilia, by damaging cilia present in the respiratory tract, and this leads to thickening of the mucus. The mucus is not getting cleared, so thickening of mucus, and all this leads to mucus plugging, mucus retention, right, and obstruction in the respiratory tract. Apart from this, direct effect of smoking is it causes a direct chronic cough in the patient. So other direct effect is it leads to chronic cough. So chronic cough, the chronic dry cough of smoking has its own ill effect. Okay. Apart from this, what other thing which smoking does, the indirect effect, it affects the natural immunity of the patient, and also this affected natural immunity cause chronic infection, and especially the upper and the lower respiratory tract infection. So it impairs the innate or natural immunity of the person, and this leads to chronic infection of respiratory tract, particularly because of the direct effect of respiratory tract, right? Direct effect on the respiratory tract, chronic infection. So URTI, LRTI, these are more common in smokers. Apart from that, toxin present in the smoke. Now coming on not the direct effect of the smoke on the respiratory tract, rather than toxin present on in the smokes. The toxin present in the smoke causes damage of the lung parenchyma, and this can lead to association of lot of respiratory diseases in these patients. So toxin or cigarette smoke, toxin in the cigarette smoke, right? Toxin in the cigarette smoke causes parenchymal lung injury, parenchymal lung damage, right? It causes parenchymal lung damage. And association of COPD has been seen 30% in the smokers. Now risk of perioperative respiratory adverse effects, the incidence has been seen to be 30% increased in the smokers. So increased incidence of perioperative respiratory adverse effect, perioperative respiratory adverse effect is more in the smokers. The risk of hypoxia developing intraop is more in the smoker. So more predisposed to hypoxia, These patients are more predisposed to, the individuals are more predisposed to hypoxia. Why they are more predisposed to hypoxia or hypoxemia? Why the smokers are more predisposed to hypoxia or hypoxemia? Now there are multiple reasons for this. The first is in smokers, the functional residual capacity is reduced, the closing capacity is increased, so alveoli collapse. The alveolar collapse is more commonly seen. Then the ventilation perfusion mismatch is higher. Atelectasis, increase in the incidence of atelectasis has been seen. So reduced FRC, functional residual capacity, then your increased closing capacity, then your atelectasis, in the association of atelectasis, because of reduced FRC and increased closing capacity, your impaired VQ mismatch, impaired ventilation perfusion matching, all this predispose the patient to hypoxia and hypoxemia, less oxygen being delivered to the tissue. Now anesthetists should be aware of all these ill effects of smoking on the respiratory system, and should be aware that in smoker, the risk of hypoxemia or hypoxia, or risk of adverse event, is highest during induction and during emergence. So these are the two time periods they have to be extra vigilant. Okay. So what I'm trying to tell, that during induction of anesthesia and during emergence from anesthesia the risk of respiratory complication is highest. The risk of respiratory complication is highest, right? So risk is highest during induction and emergence. So we need to practice extra precautions. What are the important complications which can happen during induction and emergence? Bronchospasm, laryngospasm, hypoxia, right? So bronchospasm very commonly seen in the smokers, then laryngospasm, then hypoxia. Now these complications the respiratory adverse effect may be seen, right? So perioperative adverse events is more in the smoker. And not only this, as an anesthesiologist we have to know, yes, in smoker there is a risk of perioperative respiratory adverse effects. We have to very properly ask about their history of smoking, that how many pack years of smoking they have, because more the pack years, more is the association of the adverse effect, right? It's kind of directly proportional to the number of pack years the smoker have. So what do I